Assalamu alaikum. Dalum Clinical Consultation Day. First scenario, Mr. James, 60 years old, present with weakness. Please take history, examine the patient, and address the concerns. Yeah, here you go, Dr. Ala.
Hello, I'm Dr. Ala. I'm the doctor in charge today. Let me confirm you are Mr. James, 60 years old. Hello?
Dr. Abdullah?
I'm sorry. Yes, doc. Yes, I am.
Mr. James, I'm here today to discuss with you about your health condition and to examine you. Is that okay with you?
Yes.
It came to my knowledge that you have been troubled with weakness. Is that right?
Yes, doctor. Actually,
Yeah.
I'm really getting weak, and this has happening over the last, you can say, 4 to 6 weeks.
I'm sorry for this, Mr. James. What do you mean exactly by getting weak?
So I noticed that I'm unable basically to start to move off the bed. So when I want to sit up, I wake up in the morning. I notice that I need to slide on the bed so that I can move. So I'm unable to put my legs on the ground so that I can stand.
Yeah, I'm sorry for this, Mr. James. So you mean the weakness is all over your body or a specific part of your body?
I feel I'm not sure in my arms or hands. I'm not sure, but the legs for sure is there.
Okay. And this has started 4 to 6 weeks, as you have mentioned. Is it progressing, like it is increasing, or it's the same since it started?
Yes, absolutely. It's worsening.
It's worsening. Okay. And do you feel your arms and legs, do you feel them like floppy or stiff?
I don't know.
Okay. Do you feel difficulty in combing your hair or getting up from a chair unaided?
Yes, absolutely. Yes, I find it difficult to put my arms up and also to stand up from the chair. Yes.
Yeah, I'm sorry for this. And this is the first time to have something like this?
This is the first time, yes.
Okay. Do you feel difficulty like in opening the doors or handling things with your hand?
No.
Okay. Do you feel any pins or needles in your in any part of your body, in your hand or feet or
No.
legs or in the face?
No.
Okay. Do you feel any headache?
No.
Any vision problem?
No.
Any unsteadiness?
No.
Any shakiness of your hand or shaking
No.
in your body?
No.
I'm sorry for this question. Any problem in controlling your water work or back passage?
No.
Okay. Can I ask you if you have any history of long-standing disease I should be aware of?
No, I don't have. Well, I had my thyroid. I take the replacement. Yeah.
And since when you have this problem?
It's a long time and like years. You can say 10 years, and I'm on the thyroxine, and I follow with the GB the levels. He's happy.
Yeah. And how much thyroxine you are taking?
I take 50 microgram.
50 microgram.
Sorry, 100. You can say 150 microgram. Yeah.
150. Any new change in the doses or any new added medications?
No.
Did you start any new medications recently?
I took antibiotics in the past month also, but courses of antibiotics because I had flu, and it's fine. I recovered the flu, but I think I took steroids also. Uh, uh, so I'm not sure. Am I weak from the steroid also? Yeah. Answering your new medications, so that's only the medications and the thyroxine.
And regarding the antibiotic, do you know the name of the antibiotic that you have taken?
Maybe yeah, amoxicillin, yeah.
And for how long you took it?
I only took so I took two courses, each one 7 days.
7 days. When was the last one?
It was before 2 weeks.
Before 2 weeks. And regarding the steroids, why you took steroid?
Because I was really unwell with that flu, so the GP gave me the steroid. I don't know. He thought maybe that's infection.
And for how long you took it?
Also, I took it with antibiotics, so he gave me short for 2 weeks.
2 weeks also. And you stopped it?
Yes, I did. He told me to stop.
How much? Do you remember the dose that you were taking from the steroid?
I took 30 milligram.
30 milligram. And you stopped it directly, or you decrease the dose gradually?
No, they stopped it directly because they said it's a short time.
Okay. Any other medications you are taking?
No.
Any other condition apart from this thyroid problem you are being treated from?
No.
Okay. Do you have any joint pain?
No, I don't.
Do you have any skin rash?
No.
Do you have any skin changes? Change in the color of your skin?
No.
Do you have any eye pain or eye problems?
Like what?
Like problem in your vision, red eye, discharge?
No.
Okay. Do you have any high body temperature?
No.
Did you notice any change in your body weight?
Yes, I feel there is some change. I lost weight with this weakness.
Yeah, how much weight you lost?
I think I have lost around 5 kilo in this 2 months, maybe.
In 2 months. And this loss of weight, did you intend to do it, or it's like unintended?
No, unintended.
Yeah. What about your appetite?
Appetite is okay. Appetite is okay.
Okay. Did you notice any okay. Did you notice any lumps or bumps in your body?
No.
Did you notice any sweat or excess sweat?
No.
Any cough?
No.
Any shortness of breath?
Only when I got that infections, I was feeling short breath slightly, but that improved with the flu improvement.
So when you got the flu, you got shortness of breath? Okay. Do you have history of recurrent infection?
I'm sorry, and the cough also with that shortness of breath. No, I don't have previous history of infections. No.
Okay. Any chest pain?
No.
Any leg swelling?
No.
Any tummy pain?
No.
Any change in your bowel motion?
No.
Any change in the water work?
No.
Okay. Do you smoke?
No.
Do you drink alcohol?
No.
Okay. Can I ask you what you do for a living?
No, I'm retired. I'm retired. I was in office job.
Yeah, and any impact for this problem in your daily life?
In my life, of course, yeah. I really struggle now with walk. I'm unable to walk at all, basically.
Yeah, I'm sorry for this. Do you drive, Mr. James?
No, I don't drive.
Okay, Mr. James, I'm sorry for your suffering. I hope we can help you regarding this by giving you the proper diagnosis and treatment for your condition. Can I examine you?
Yeah.
Okay, I'll start my examination by checking the patient observation chart for the vitals.
Mm-hmm.
Vitals are okay.
Vitals are okay. Yes, vitals are within normal.
Okay, I need him to elevate his hand up to check if he can elevate both arms up.
So he can elevate. He can
arms?
elevate with difficulty.
Okay, and legs also he can elevate?
Legs, no, he can't.
Can't elevate the legs. Okay, I need to check by inspection. There is wasting.
You can notice wasting. Yeah.
Okay, there is any fasciculations?
No fasciculations.
Okay, there is any special feature in the face of the patient, like
No,
frontal balding, anything?
there is no special features.
Okay, so I'll start the neuro examination from the upper limb. I will do check the tone around the shoulder, then around the elbow, then around the wrist.
Tone is normal.
Tone is normal. Then I will ask for the power. Okay, around the shoulder, around the elbow, also abduction, adduction, and the power in the upper limb, proximally and distally.
Okay. So shoulder abduction is 3/5. You can say the left is weaker, also 2/5, and then adduction is 4/5 bilaterally. And also now we have the flexors are flexors and extensors are
I need it's like proximal, you mean more than distal, or distal more than proximal?
proximal is more than distal, and
Okay.
abductors are more, yeah.
And the lower, because the time, and the lower limb also, the
Lower
proximal
limb,
more than distal?
lower limb, yes, proximal and flexors are also significantly weaker. Extensors are stronger.
Proximal, okay. And the lower limb, the abductor, weaker. Sorry, the abductor.
Adductor is stronger, and abductor is weak, very weak.
Okay, there is any sensory affection?
No.
2 minutes left.
No sensory affection. Okay, then I need to check cerebellar, any abnormality
Normal,
in coordination?
Normal.
Okay, okay. In the patient face, there is any abnormality, deviations or anything?
No.
Okay, so thyroid, there is thyroid enlargement?
No, there is no.
No goiter?
No, there is no. It looks normal. You don't have any palpable goiter or thyroid. Yeah.
Okay. The heart, can I auscultate the heart, the apex and the base of the heart? There is any murmur
No,
or
yeah, S1 and
any...
S2 is normal.
Okay, can I ask the patient if he is able to stand from sitting position or he cannot?
No, he is unable.
Okay, can I know what's your concern?
What do I have, doctor? And is it treatable?
I appreciate your concern. I'm sorry, can I ask about the blood pressure, supine understanding?
It's there's no difference.
Okay, I appreciate your concern, Mr. James. Actually, from my examination to you and our discussion, there are multiple causes, maybe related to your thyroid problem. Maybe it's affected by the flu that you got recently and the medications that you have taken. And also it may be related to the steroid that you have taken also and stopped. So we need to run some blood tests and I need to admit you, and then I will come back to you
Okay.
then to discuss with you the result of the test and the plan of management.
Time is up. Okay.
Okay.
But
Okay.
Thank you.
instead of saying I will do for you, you can ask for another concern.
Other concern, yes, yeah.
Okay.
Yeah.
The time
Okay.
is not good.
Do you have any other concern, Dr. Abdullah?
No.
Okay.
Mm.
Now the examiner questions.
Okay, so what? Give me a summary of your case and your differential diagnosis.
Okay. 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 So this patient presented with a history of sudden onset, as he mentioned, of weakness that started like 4 to 6 weeks ago, and it's progressively increasing. And also he has past history of thyroid problem, mostly hypothyroidism and thyroxine. And he had recent flu, and he was taking amoxicillin antibiotic and steroids for 2 weeks. He has also positive history of loss of weight of around 5 kilograms with a good appetite, and he had chest problem during that flu. During my examination, I could appreciate that he has signs of lower motor neuron lesion with weakness that affecting proximal muscles more than distal. He has wasting also. So I couldn't appreciate any other positive findings. Sensation is intact all over, and also there's no affection of the coordination. So my first differential, it can be related to the control of his thyroid problem. Maybe it is hypothyroidism, although he mentioned that he is following regularly, and I don't think the medication that he has taken it's affecting the absorption of thyroxine. The second one that he had adrenal insufficiency, but also my third differential maybe
What is the second differential? Sorry.
adrenal insufficiency.
Okay.
The third differential can be motor neuron disease, okay, with progressive muscular atrophy that affecting the muscle, but I don't think it will come like that fast.
Okay, but I'm sorry. I will discuss later. I cross question, but
Yes,
okay,
yes.
continue the investigations.
So for this gentleman, I need to admit him. I will do for him full blood test and including full electrolyte panel also to exclude any electrolyte disturbance.
Good.
The other thing that I need to do for him also thyroid profile, TSH, T3 and
Did you say
FIT4.
CBC? Did you say blood tests? Normal blood, full blood count. Okay.
Full blood count, and also
Okay.
including the full electrolyte.
Okay, I'm
And
sorry for
also-
interruption. Yeah.
And also
What
the
else?
thyroid profile.
Yeah,
Okay.
what else?
And I need to do for him also I can do for him also short actin test to check for adrenal insufficiency. And I need to do for him a nerve conduction study, and I need to do also EMG.
Very good. Okay. Why
The other
EMG?
thing that I can EMG to check for any muscle problem. If he has any muscle problem.
Okay. So okay. What else you can do? So say EMG. Can you formulate again your? Okay. So what do you think the first differential?
Because it can be Guillain-Barré syndrome.
No. Okay.
Although it's proximal more than distal. Yeah. Okay,
Okay.
so I can do also, yeah, I can do for him also muscle biopsy to check for any
Very good. Yeah. Muscle biopsy.
muscle
Yeah.
lesion.
And before muscle biopsy, anything in particular, like before muscle biopsy, anything to help with, that you would investigate?
The AMG, the
No, you said
nerve
that.
conduction study.
Okay. How you will manage?
I need to admit the patient, okay, and according to the result of the blood test, I need to refer him.
What is the
to a
reason of admission?
The reason of admission that he may have acute either for the workup mostly the admission will be for the workup to figure out the cause of his like acute neurological deterioration that he has, and I will refer him to a multidisciplinary team including the neurology, the physiotherapy, the occupational therapy, and also the specialized nurse. And depending on the result of the test that I have done for him, we will do the further management depending on it.
Okay. Okay. What other any medications you can think of, or what you can, or other teams apart from the neurology and the MDT? What other teams you can?
It is if it is like endocrine problem, the endocrine.
Okay. Good. Yeah. Okay. Medication wise, any medication you want to give?
Actually, according to the result of the test, but if it's like severe hypothyroidism, I will give him thyroxine.
Good.
Okay. Depending on the result of the test and also the condition of the patient, and if he can tolerate oral, or sometimes we can give him IV thyroxine. The other IS, and also if sometimes there is this cytotoxic periodic paralysis, but it's not cytotoxic.
What do you think about
I get confused.
If you are suspecting something? Have you asked for ESR or antibodies? If any autoimmune condition, do you want to give any medication?
Yeah, I didn't ask about muscle pain or muscle tenderness, and
it's negative. But is there any? He has some hip pain. Actually, he has some pain in his thigh.
Polymyalgia rheumatica.
You're close. Something very. Okay. Don't worry. So, what medication can you give in this case if you are suspecting?
Steroids.
Okay. And what else with the steroid?
I think if it's polymyalgia rheumatica, it will be steroids.
Okay.
Polymyalgia rheumatica will not cause wasting.
So, okay. So, have the time still, or?
No, it's 8 minutes.
Oh, okay. So, what MDT you can involve in addition to the physiotherapy and occupational therapy you mentioned? What other you can, and you didn't actually focus on the something that's related to the patient's ability to. It's part of the MDT in maybe related to the muscles.
Yeah, I mentioned the physiotherapy, the occupational therapy.
In any neurological case, what you will involve apart from the physio and occupational?
Yeah, if there is a swallowing problem, you mean?
Good. Yeah, speech and language. Okay.
Yeah.
Okay. So Okay. So if I give you a chance to give another differential. So this patient has a proximal, and it's more proximal, and thyroid was stable. There is no drop in blood pressure when he's standing. He has this thigh pain. What you may think of
Polymyositis.
okay, good. In polymyositis, what investigation apart from muscle biopsy?
The anti-Jo1 antibody.
Okay.
The
Okay.
autoantibody profile, including the anti-Jo1 antibody.
Okay. Okay. Any advice of the patient? Say he improved after treatment and he wants to go home, and he is on. So how you will counsel him? What do you imagine that he will be having treatment plan?
For the polymyositis, I think the most important thing is the counseling about the steroids and
Good. Yeah. Okay.
the adherence to the treatment and the regular follow-up and the bad effect,
Okay.
side effects of the steroid.
Good. Good. Okay. Yeah.
So I
That's
missed
it. Yeah.
I missed the muscle pain and like this and the
So
stiffness.
because it's a proximal and there is this key features of the adductors are stronger. So in this case, it will be the first thing in your mind, the muscular weakness due to muscular disease. So and you can say just muscle disorders. So that's a group of disorders. It's not easy to say polymyositis from the first time. It's very good you said it. So he has actually is being also symmetrical involvement, and there is no the reflexes. Did you check the reflexes? I didn't think reflexes are only diminished at the areas of the maximal weakness, which indicate that this is something more going with the non-neurological problem. And also he has so there is something very important in this case also. That's that problem. If you didn't figure out that this is polymyositis, maybe I made it difficult this way because you need to think about malignancies, and you didn't ask him about any bleeding. So he has the rectal bleeding also, which he may not focused on that during this weakness that's happening to him. So the rectal bleeding would alarm you to that you should and also in the workup you will do full screening for malignancy. You in female you do mammogram, and in males, and also you will do upper and lower endoscopies. You will do CT scans of the body, and for the so this is a malignancy workup, and you do tumor markers, but it may not be very useful or maybe negative falsely. So 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 let's start from the history. You analyzed well the things, just you didn't ask about the bleeding. You focused on the red flags of malignancy. He has some. He has weight loss, and he's tired. So and also he has on examination also there is nothing much I can comment.
Yeah, let's
Good.
do it in a skill wise.
In a
Okay.
skill wise from the beginning. Okay.
Yeah. So physical examination, he did
No,
all the steps.
I was going to say first the analysis and then this it will help in the skills. Okay.
Okay. The clinical communication, what he missed in the history,
Yeah. So
the
no,
bleeding
in the history, the bleeding. Yeah,
and the
or more.
appetite.
No, he asked about the appetite.
He asked about appetite.
Yeah, but
But I remember you said it's preserved. Appetite was okay, right?
yes,
So how he can
appetite
think
is okay.
about
So
Yeah,
cancer?
that's what made me confused, that the patient
Yeah.
has preserved appetite.
Suppose. Yeah.
So I thought the lost
no,
weight from
so
the wasting.
no, it's not. It's not in the differential diagnosis. It's not in the diagnosis. Just to remind in the investigations, in your analysis, in your discussion, because he has also even if he has bleeding, it could be from.
Is it a cancer, Dr. Abdullah, or no? The case here.
No, it's not.
Okay. What the diagnosis? Because also we cannot
It's
ignore.
polymyositis. No, it's first polymyositis. You need to say this is the first differential polymyositis with the possibility of malignancy need to be ruled out. Other differential is given that he has thyroid hypothyroidism, so
The
there
disease
are two
itself, the
ways.
hypothyroidism.
There are two ways of differentials in this case. Either you say the differential of the myopathy itself, so it's broad, idiopathic, idiopathic or inflammatory, which is polymyositis, and there is the endocrinopathy can lead to myopathy presentation, and there is the overlap syndrome, which you didn't ask in the history, and
He asked about
also
skin rash and
only
joint
skin rash, but you
joint
didn't ask
pain.
about dryness, which is very important in the mouth and eyes. You didn't ask about the photosensitive rash, um,
He asked about
which
rash and skin change. He specified, right? He asked about it.
yeah. He asked about skin rash and joint pain.
Yeah. Okay, continue.
Okay, can be fine. Okay. Family history was not asked about.
Yeah, he missed the family. Yes, I agree.
Yeah, that's the point only, which
Okay.
can be important in family history of malignancy in this case, also. So examination is fine, is totally fine. Just the plantar responses was important also. It would be helpful, like not to miss it. Also, so you checked the fasciculations, you check for atrophy, you checked if how is he doing, is he able to stand or not? That's good, and you did check for you checked for the power, you analyzed it, it compared upper and lower, and the tone and the coordination, and the thyroid. Okay, and now we want to go for you listen to the chest, I think, and that's good. So given the differential diagnosis now, so I said we can say the in terms of the myopathy, or can be discussed as in this case muscle disorder, muscle polymyositis. Given that he had some you didn't analyze the state of this flu. He can be staying on the bed. Is that something that affected his muscles, maybe, and he was so acute. Well, it's not critical illness myopathy, which is, but he was staying on the bed for many days. That's possibly that's critical muscle myopathy, which can be involved, I think, in this case. Another differential is you need to think about steroid or medication, other medication. Did he take over the? Was he prescribed statin for the cholesterol or any, which is a common medication? Steroid. He was given that short time. I know it. You didn't, but to be involved, medication induced. Motor neuron disease to be involved here is totally not doesn't make sense, I think, because it's not distal. There is no fibrillations. Bulbar muscles are intact. In terms of investigations, you did very well. I was trying to hint about the imaging, which is MRI for the muscle. You will do MRI for the thigh, which is the area of the thigh pain. Management, admission, MDT involved. All the aspects are said, and you will do careful observation to avoid falls and nursing management. And you will involve neurology, of course. You will involve endocrinology, as you said, and in terms of steroid and also steroid sparing agents. In this case of polymyositis, you need to steroid or other cytotoxic medication, what they call it, immunosuppressive medications, and also not to go deeply in the in that aspect, but other agents can be given in steroid resistant. So if it didn't improve, you will give IV immunoglobulins. So it's the challenge here is the malignancy to be looked for in investigation and to be ruled out. So I would consider in the communication. In the communication, I would say 2, adequate, and differential diagnosis 1, borderline, judgment 2. Examination is 2. There's no trouble. And concerns, I would give it 2 actually, but I didn't make it difficult. So yeah.
Why he didn't answer the concern? Why you want down the concern marks?
No, I made it easy. I only gave 1 concern, so no problem. 2 marks.
Okay, so you are talking as one examiner, and I'm the second one, right? It's okay. So your judgment as half of the mark, 2. 2.
No, judgment is 2.
Okay, 2 means still you're minusing him, right? Why?
No, I'm sorry. The full mark is for 4. Me it's 2. Sorry, 2 4 is for 2 examiners.
4 for both examiners.
So
4 and 4. Yeah, 4 and 4.
I'm sorry. So for all of them, no, I think Dr. Basim is 2 for each one.
No, 2 borderline. Unsatisfactory 0.
Okay. I see. So 4 for no. So it is satisfactory. Okay. It is satisfactory for all of them except the differential diagnosis.
Except the differential.
Borderline. Yeah.
Okay. The physical examination, for me, I want to down him because he didn't do the reflexes. Okay. Suppose to do the reflexes. He did the tone and power, but he didn't do the reflexes. For me, it's very important because it can give a clue of either because also he mentioned it correctly, but he didn't confirm it. So it's lower motor neuron lesion. The reflexes can help him to rule out GBS because he put it in the differential. And GBS usually the reflexes will be a reflex, yeah? Right?
Yeah, and GPS is very important differential. After the
Perfect.
flu, you think about it.
Perfect, yeah, he put it. So I can minus this one only for that reason. They identified the find he could pick up all the finding. The clinical communication I will minus only for the point of travel, family history and travel. He didn't ask about social and HIV as well. Although there is the history was long from your side. I mean, he had or the patient had a lot of finding. That's why he was taking time to pick up this finding. But he did everything perfect in the clinical communication. I mean, in the history taking, he asked about the constitutional. Maybe also you distracted him when you mentioned no appetite. And I believe any cancer patient he has lost appetite. Okay, so supposed to be lost. Anyway, the clinical communication will be minus for this reason.
Okay.
The differential, I don't think he can put cancer as long as the appetite was preserved. But he put
Okay.
the Addison as stopping after stopping the steroid. He put the steroid itself, right? You put the
No,
steroid. He didn't
I
put.
don't know. I said it. I didn't bought it, but um,
Okay, but
Because he
at least
stopped
he
already the steroids, so I didn't put it as a differential.
still the effect will be longer. Okay. If you
mm,
want to add for the examination steps, the Cushing, but you ask about any characteristic face, which is good
Yeah.
also.
yes. Yeah.
The stria, I want to mention if you want to examine the abdomen for stria. Back to the differential. So the either stopping the steroid as adrenal insufficiency or the steroid itself. This is the second differential, or proximal myopathy for differential, drug induced or polymyositis, as you said, and
But
the cancer. Yes,
it's not like isolated proximal. So the distal are also were involved like in a 4/5. So um yeah, it can be put as a differential, but I mean it's not the all the different. It's not the case
not
here.
proximal, but he asked you where exactly the weakness, and you mentioned it's more proximal and more
It's
abductor,
it's
right?
it's more, but it's not isolated being proximal. I mean in the discussion and case, not to be focused on just it's a case of proximal. You know what I mean?
Yeah, so the
Yeah,
differential
yeah.
will be going more to the GBS. If you want to say it's all diffuse weakness, you can put differential of GBS.
You can. Um, but the main differential you will think you need to think about muscle here.
Okay, muscle
Or
in the
in
form of dermatomyositis or polymyositis, you want to
or
say?
yeah.
So I have to put a cancer clue in the scenario, like loss of appetite, and he will go with the cancer screening.
Okay. Mm-mm.
Okay,
I
and
agree. Yeah.
he can be also smoker, heavy smoker.
Okay.
If this one is smoker, the patient was a smoker.
No, he's not.
Okay, maybe you put it as GI cancer. It's okay. You can,
Okay.
but
Yeah,
still
I agree.
the appetite must be lost.
I
I believe
agree. Okay,
most of
I
cancer
agree.
patients. Yeah. Okay. The concern, as I commented on spot, whenever you have one concern, answer it shortly, Dr. Ala. Doctor, what do I have? You might have possibility of X disease. Okay. You have other concern? Yes, doctor. What is X disease? Explain X disease. You have other concern? Doctor, is it running in family? Explain, is it running in family? You have other concern? Okay, Dr. Ala, because you might have up to six concern. If you answer one concern lengthy, and we will do the one, two, three, we will do investigation, we will admit you, we will do management, we will call group of doctor. One concern already wastes your time. That's why I always say, please answer shortly. What he asked, answer it as short as the answer is related to his question. Okay, to the point. What I have, you have a condition called for this, for example, Brooks myopathy. he will give him the chance to express, doctor, what is the proximity? Now you explain it. Doctor, what you will do for me? Okay, I will admit you. What investigation you will do for me? I will do blood workup. Is it running in family? Yes, it's running in family. Or no, it's not running in family. In this way, so you can cover the all concern. Believe me, no scenario with one concern. Always they have a lot of concern. Sometimes they will be concerning about the job. Can I do my job? Can I go back to my work? Can I drive? If you don't answer those, they will down you in this skill. So give them the chance to comment and to ask you about what they are concerning for. Okay? This is my comment regarding the concern. The welfare, of course, maintained as long as you didn't do harm to the patient. The yeah, I believe Dr. Ala did perfect in the all overall performance, but maybe missed one or small things that couldn't help him to reach to diagnosis. Before giving the chance to comment, Dr. Ala, can you write the scenario in the chat box for Dr. Amar?
Okay, Dr. Bassem, I'll put it.
Okay, CK, I saw it in the chat box. One of the
Oh,
important
CK. Oh my God.
CK,
Yeah, yeah.
creatine kinase is very important. Whenever you have muscle issue, do it, please. You mentioned EMG. Okay, again, if you go back with the investigation in the approach as I prefer, general, specific, bedside, imaging, and finally the invasive, you can do all of them and you will not forget any of them. Let's start from the general investigation, CBC, ESR, and inflammatory markers to if there is suspicious of infection or inflammation. CRP, inflammatory, and the procals, as well as the ESR. Supposed to do them, coagulation profile, liver function, kidney function. Okay, as baseline investigation. Now this the rule of specific. Specific CK, creatine kinase. If you want to add something else, you can do for a thyroid function because this patient is having thyroid. I want to check his thyroid state. And by the way, try to mention what the patient thyroid state right now. Is it AO? Is it hypo? Is it hyper? And you try to roll out by loose motion. You roll out by the mood. You can roll out also by sweating, shakiness. I think you ask most of the question can give you help or clue if this patient AO or hypo or hyper. And try to mention it whenever you are presenting the case. I have this patient presented with 1, 2, 3. He had history of thyroid, and I guess he is in thyroid state right now. You can add it to your presentation. We finished the specific investigation, CK, and thyroid function test. The bedside test, you can do ECG, you can do echo, you can do chest X-ray, ABG, and urine dipstick. If you suspect cancer, you can think about imaging. In the imaging, CT cap for chest, abdomen, pelvis. For the invasive, you can do muscle biopsy. Yeah, bedside test also you can do AMG. I forgot to mention, okay? By this way, you will not forget any of these tools, how to investigate. Okay, Dr. Omar, your scenario, you are the doctor in the acute medical unit. Patient name, Miss Sarah Adam, 22 years old, present with seizure. The blood pressure normal, temperature is normal, the pulse is 80. Doctor, okay, someone asked how many borderline to be didn't pass in long clinical NCC. You mean clinical communication, right? It's not a matter of one station. It's collectively calculating the marks all over the stations. And there is mark of pass for every skill. Okay, you have to be aware about the skills, how they are judging, and how to pass every skill in the all station. In summary, at least don't have unsatisfactory. Unsatisfactory mean you have -4 mark. يعني means 0 out of 4. Sorry. Yeah, Dr. Omar, you can comment now.
السلام عليكم دكتور علاء دكتور عبد الله دكتور باسم. How are you doing everyone?
معاكم سلام دكتور عمر.
دكتور علاء when you reach your differential I give you a thumbs up if you remember when you said that the patient does have a proximal weakness, a picture of lower motor neuron in keeping with proximal weakness. The differential for proximal weakness, if you want to approach it your way, this way that you proposed, you should have continued because the proximal weakness in this short term, it means that the lesion is likely as in the muscle, so it's myopathic. If it's myopathic, you need to think, is it dystrophic or non-dystrophic? This patient doesn't have any clue of dystrophic. Forget that you might didn't get the case, but continue with your differential. If it's non-dystrophic, then it would be inflammatory, like the dermatomyositis, polymyositis, inclusion body myositis, or endocrinopathy related, which is thyroid related, etc. And the third one would be drug induced. And the most important to keep in mind is the rhabdomyolysis. Drug induced is the steroid statin or the third one, which is the third drug. It's not a drug, but it's with a drug, which is alcohol. Okay, alcohol myopathy. So you've been there, but then you've left your differential and went to something else. Second sensible differential to add is Guillain-Barré, but you said against that I couldn't appreciate any weakness, any pattern in keeping with Guillain-Barré, because Guillain-Barré is demyelinating peripheral neuropathy, okay, and starts from down to up. And you didn't identify in your history that it's going with that, so you can keep it lower and defend it if the examiners are going. The scenario that Dr. Abdullah provided today is in keeping with this diet flavor. This diet, they are bringing many scenarios that it's flooded with multiple information. I shared with you, Dr. Ala, the scenario that came to me as a long consultation. It was kind of similar thing that's what's happening today. Did you get the point of differential, Dr. Ala?
Yes, yeah, I got it. Yeah, I got it. From the start, yeah, I put proximal myopathy. Then I went to other causes like for distal, even causing distal weakness without sensory affection. And
Yeah, but
yeah,
so the general
I,
flavor you think that it is proximal weakness, then stick with it. Even if he had subtle distal weakness, neurology is not 1 + 1 = 2.
yeah,
Neurology is likely 1 + 1 = 2. So he's almost having proximal more than distal. So keep it with that. This is in keeping with his another sensible differential that so the second differential you can your first differential would be myopathy for differential diagnosis. Okay, the second would be Guillain-Barré, given that he had a recent history of
the flow.
flu. Then within your differential, he would ask you, the examiner will ask you, what do you think of this possible cause? I think Dr. Abdullah, in his scenario, when he tried to say that I've lost weight, with lost weight plus proximal myopathy, think of dermatomyositis, polymyositis, and it will be a hint to look for underlying cancer. Search. How you will search? PET scan in your investigation. This patient, I will order him a PET scan. I'm admitting him to facilitate the PET scan also. Okay. So to CT tap, if normal, then this patient would qualify for a PET scan if the diagnosis is proven down to the line. If the examiner asks you why you want to admit this patient would need a long battery of investigation. We are not sure right now what he's having. If he's if it's confirmed that it's inflammatory myositis, then looking for underlying cancer is important. And this can be the investigations, the follow-up investigation can be started for him whilst as an patient to facilitate the decision making. That's it. Sometimes if from the stress, all of your linguistic will go away. All of your ability to construct a sensible phrase will go away. So this is a chance to train yourself to to simulate the situation and to look for an answer, because if for luck, if you got a similar scenario or a similar situation where you don't know what to say, you have like a reserved backup or backup sensible phrases to say. So is that point of differential diagnosis clear?
Yeah, it's clear, Dr. Omar. It's nice.
The second thing is, if you are lucky and you're getting the same exact scenario or the same flavor, and you thought of dermatomyositis, polymyositis, how you would investigate? How you will be verbalizing your investigation. So imagine that in your exam, you get a similar situation, and now you are ready to, oh, I got it. So how you will verbalize your investigation?
So we'll go to the side of the autoimmune. So we'll go to the full blood count, inflammatory markers, and also we'll basic blood tests, especially the urea and electrolytes, and also for the muscles, the CBK. And for the autoimmune, I will do also anti-nuclear antibody, and I will do anti-Jo1 antibody. The imaging to search for the underlying cancer. I can start if he's like most of the cases that I have faced with polymyositis, they were like lung cancer.
Yes,
So we can
yes, and
do,
it's the
yeah,
most common
just,
cause of the most underlying cancer in males.
yeah,
In females, it's ovarian and other cancer. I don't remember, but they don't go deeper. What's important to them that you are minded of searching for underlying cancer.
yeah, to search for the underlying cancer. Yes, that's it.
What would be your management? And imagine this patient does have diabetes in his poorly controlled diabetes in his background. So I'm now tweaking the scenario.
So yeah, so at this point, I can think of a multidisciplinary team, including the neurology also and the endocrinology. The thing that if he can manage to take the steroids with proper control of the blood sugar, or it will be like a decision making with multidisciplinary team or other immunosuppressant medication if they cannot give the steroid.
So what is the phrase that Dr. Basim said? It's a buzzword. What is that buzzword?
The multidisciplinary team or
No. In the choosing the immunosuppression, Dr. Basim said we can give steroid or steroid sparing.
yeah.
So put in your mind, if the patient can't use a
Immunosuppression.
steroid, verbalize. If you said steroid sparing, that's it. It's
Yes,
not necessarily to know which steroid sparing. It's not for the basis level. You are not giving a rheumatology exam. So it's a steroid sparing. We will leave it for the discretion of the rheumatologist to decide. So this is the two things to add. To be honest, in the examination, I don't know, Dr. Basim, I think it will be difficult to do all of the steps of the examination. You've mentioned something clever, Dr. Ala, which is you should have asked the patient to raise from the chair in the very beginning. If he was able to, if it was difficult, then this confirms the proximal myopathy. Then you don't need to do the proximal power. You can just go for the reflexes. But even though, if your overall performance is well, this will be covered. They are not in the long communication station. They wouldn't be looking for the techniques and everything. They are looking for the overall picture. I don't know if Dr. Basim
Exactly.
can
Yes,
agree
yes.
this
Yeah, I
with me.
agree. Yeah, I agree, Dr. Ala. He can get not less than 22 out of 28. Why? Because he cover most of the things. The musculoskeletal system, looking for the autoimmune. He asked a good question. If he has skin rash or skin change, he thought about Addison as well because the hyperpigmentation. maybe the patient will not consider it as skin rash. So it's a clever question to ask: any skin rash or skin changes? Okay. Some patients, they will not look at the pigmentation as rash. So he will be more specified to ask about any skin change or pigmentation or darkening or color change. Okay. It's a really a clever question. And by this question, you can include one of the autoimmune, as Dr. Ala and Dr. Omar mentioned. Is it something autoimmune or something else? Skin rash, joint pain, back pain, all this can be a hint for the autoimmune as an autoimmune underlying condition. The second, thyroid, of course, you can put it because there is already ongoing thyroid. What I want to add as a last comment before starting second scenario, whenever you have weakness, as Dr. Ala mentioned, I like his question, what do you mean by weakness? Because he might mean the weakness as fatigue, and he might mean the weakness as neurological weakness. So you have to know what he is talking about. Is it weakness neurologically or weakness because of the fatigue and anemia? And the pathway will be definitely and deviated from the weakness of the neurologically totally. Okay, so don't start the approach without knowing what he means by the weakness. The second question for the weakness as approach, what the type of weakness? Is it floppy, as Dr. Ala also asked, or is it stiffy one? Whenever you have floppy, so you are talking about flaccid paralysis. If you have stiffy, you are talking about upper motor neuron. So the floppy going with lower motor neuron lesion, or the stiff, it will be going with upper motor neuron lesion. The side and the site and the timing, the last three things to ask. Site mean is it one limb or one leg, one arm? The site, which site exactly? The side, if you have unilateral, you are talking about stroke. If you have both lower limbs, so you are talking about paraplegia. So you have to know, is it hemiplegia or paraplegia or quadriplegia or monoplegia? This is by the mean of side and side. The last thing, and you can put it as a differential in most of the cases, the timing. Is it coming, or especially with those with floppy one, is it at the evening? Is it worsening at the evening time? What means by that? The myasthenia gravis. Any medication patient received and the weakness happened, either it could be Guillain-Barré syndrome or myasthenia gravis. The evidence of myasthenia gravis, the patient will have history of myasthenia gravis. But here it doesn't fit because it was clear no myasthenia gravis before. Also asking, is it previous or first time? It's very important because you might have something going and coming, like a condition called periodic paralysis. So the patient will present once, twice, and thrice. He can come many times with the weakness, and it come as also floppy weakness. It's very important to complain and very important to know what you are talking about. The weakness, the magic question for the weakness, I believe the magic question of weakness, is it floppy or stiffy? Floppy will take you to a group and another approach. The stiffy one will be another and totally different approach. This is the take home message. Whenever you suspect cancer, please put it in your list of differential and try to roll it out in front of the examiner rather than saying it to the patient. Unless you have highly possibility, you can tell the patient, yes, there is possibility to have a cancer. But for the examiner, they like whenever you are having a sense there is something serious ongoing. I want to roll it out. From my differential and from my investigation, I should roll this out. Here in this scenario, if there is loss of appetite, I could say I would like to roll out cancer by doing CT cap or any tumor markers. They will like the answer and they can give you full mark if you mention it in your investigation. Even it's not the case. Okay, imagine this is not the case, but still I am suspecting a cancer. Why? Because if you didn't pick up the cancer early, this patient might go home or discharge, and he will be another medical error patient. He will come later on with a cancer which is spread and metastasized to another organ. And this is another communication scenario you are facing in PACES. Patient already presented with something, and after a long time, he discovered that he has a cancer. Why? Because he was missed, and it was misdiagnosed earlier, and he came again with cancer later on, which is already advanced stage you cannot manage. Please don't do this mistake whenever you have a suspicion of cancer. Try to rule it out by your investigation and show the examiner that you are thinking about the serious condition, which is a cancer or autoimmune, something I need to pick up early to manage it early. Okay, this is my comment in general. Anyone has a comment before starting the second scenario? Any
It's just
questions?
this diet, the group of polymyalgia rheumatica, polymyositis, dermatomyositis, is coming more frequently from the feedbacks that I've heard from many candidates, from my colleagues also as well. So it is, I don't know why they are focusing this diet about this. And you can't say for sure, oh, this is polymyositis, oh, this is whatever. It's coming for discussion. This is what uh, uh, I'm thinking about, to be honest, Dr. Bess.
Yes, okay. Thank you, Dr. Amar. Yes, it's something for differential, and they like to pick up the most relevant and the most serious as well. Not only most relevant and the most serious differential you have to think about, and to show the examiner and impress him. I could think about this, and I won't rule it out. Thank you, Dr. Amar. Let's start second scenario. Dr. Ala ready? Dr. Abdullah ready?
Yes.
Okay, here you go.
Hello, I'm Dr.
Hi,
Abdullah, one of the
doctor.
doctors. Is this Sarah Adams?
Yes, Doctor,
You
I
are
am.
22 years.
Yes.
Um, Mrs. Sarah, I'm here to ask you some questions, examine you, and address your concerns. Would you tell
Okay,
me
doctor.
what brought you into the hospital?
Actually, doctor, today I had this attack of fits, which is the first time to happen to me, and it's like, it was a very bad experience to me.
I'm sorry for what you're experiencing. Would you describe to me how many times you had these fits, and what were you
Only
doing?
only one time, doctor. Today, only the first time.
Okay. What were you doing when that happened?
Nothing, doctor. I was sitting in the living room watching TV, and I had this fit.
Okay. And I'm sorry, I hope you didn't injure yourself.
No.
Okay. Was there anybody with you at that time?
Yes, my brother.
Okay. And so how long did these fits happen? This fit last?
Actually, he told me about 3 minutes.
Okay. And before it happens, did you feel anything in particular? Did you remember any smelling sound, weird smell, or
Mm,
tasting weird burning thing?
no, doctor. No,
Did you hear any noise?
no, doctor.
Okay. Was there any problem in? Did you feel there's something coming?
No, I don't remember.
No.
No.
Okay. What is the last thing you remember?
Nothing, doctor. I was watching TV. Then after
Okay.
this,
Okay.
I
Okay.
found everyone around me, and I was
Oh,
a
I
little
see.
bit confused that time also.
I see. And
Mm.
did they measure your sugar, and was it low or anything?
Yeah, I think they did it in the ambulance, and it was okay.
It was okay. Okay. And
Yeah.
do we know if the blood pressure also was low or any time?
No, I don't know, doctor.
Okay. Nothing before it happens. It lasted 3 minutes, and when you recovered, did you remember? Do you recovered quickly, or do you remember it took a time?
It took time, doctor. I remained like for some hours confused after that.
For how long you were confused?
I think like 4 to 5 hours.
Okay. I'm sorry for that. And when did you fall or hit yourself or
You mean
when that happened, the fit?
when happened?
Mm.
I don't think I
Hello.
hit myself, doctor.
Okay.
No.
Was there any movement or of the hands or legs or the body?
Yeah, my brother told me my whole body was shaking.
Whole body was shaking. Okay. And
Yeah.
did you feel did he say you went stiff also?
I don't know, doctor, but he told me I was jerking all my body.
Okay. And you lost your consciousness.
Yes.
Okay. And I hope you didn't cough or you choke.
No, I don't think so.
Okay. So did you have any infection before that, like a flu or upset stomach?
No, no,
Okay. Any did you okay, in general, did you have any difficult problem in your vision?
no,
Okay. Did you have any problem in or before that even, did you feel any problem in your speech
no,
or any problem like weakness in your face
no,
or hands or feet after you recovered? Do you remember?
no.
Okay. And have you lost your I'm sorry for that. Do you feel you had wet yourself?
Yeah, unfortunately, yes, doctor. Yeah.
Okay. Um, and sorry, that happened what time?
Today in the morning.
Today in the morning. What time exactly?
Yeah. I think around 9 a.m.
9 a.m. Okay. And in the past, did you have any problem in the childhood or any similarities?
Yeah, my mom was telling me that I was diagnosed with a condition called absence class epilepsy or
Okay.
mal epilepsy, something like this. But I wasn't
Mm,
taking any medication. The doctor told that it will like go by itself.
How long did it last?
I think it was when I was young, and and it's improved by itself.
Okay. And
Mm.
any other medical conditions such as um, any other medical conditions? Asthma? There's no asthma or any
No,
other medical conditions? No diabetes
no,
or high sugar, I mean. Okay.
no,
Any family history of similar pets or
no.
okay. And do you get any history of troubles in your stomach? Do you have any nose is feeling sick? Do you get throwing up or feeling sick?
No, doctor.
Any tummy bowel issues? Is it loose or harder?
No, doctor.
Okay, I see. And is there any have you got any problem with um, like weight loss or weight changes in
Yes,
general, like weight gain? Okay, yeah. Like
yes,
how many
doctor.
weight? Oh, yeah,
Yeah, I lost 15 kilograms over the last 5 months. 6 months,
I
sorry.
see. I see. And um, and have you lost your appetite also?
Mm, no,
Was
somehow.
there any intentional this weight loss, like you were doing any exercise or like not
No, doctor.
eating?
I did surgery for it.
What surgery?
Uh, Bariatric surgery.
I see.
Mm.
Okay. And so you're happy with the results?
Yeah,
Okay.
yeah, it's okay.
What type of bariatric surgery do you remember? Is it did they take the stomach, or did they there are like different
No, doctor.
types? Okay,
No,
okay,
I don't know.
okay. It's fine. And so was the surgery complicated by any chance?
No,
Okay. And have you got any troubles if you swallow or after you eat? Were you tolerating food? Do you get like, I mean, trouble after you eat? Distension in your tummy, for example?
At the first time it was difficult, but now it's okay.
Ah, I see. That's good. Okay. And have you okay. So back to the have you got any issues with I will ask you about some complaint in your body. Do you feel any have you got any cough
No,
problem in your chest, like a
No.
shortness of breath, or okay? And have you got any palpitations of your heart or feeling your heartbeat jumping?
no,
Do you get any chest pain?
no,
Okay, any faint or about to faint or before the seizure
no,
episodes? Okay. Have you got any do you get any joint pains, such as in your hands, or any joint pain?
no, no joint pain, but I have body aches.
Body aches, okay. And for how long this is happening?
I think it's like long time now, maybe for 2 months now.
2 months, I see. And is it worsening?
Yeah. No,
Oh.
it's the same.
Okay. And body aches, is it associated with also feeling tired or like being tired in general?
No,
Okay. Any sore throat?
no,
Any night sweats?
no,
Any lumps or bumps?
no.
So body aches, where exactly? So where in the body is it?
I think it's all over my body and
All over.
my bones and my muscles. Yeah.
And have you sought advice medically?
No, doctor, it's not that bothering.
Okay. Any skin rash or discoloration or any abnormal area of skin?
No,
Okay. Okay. And have you got any problem in your water work? Is it getting red or any increase or decrease?
no,
Okay, I see. And do you take any medications regularly for anything?
no,
And have you got any over-the-counter medication, like
No.
painkillers or any other over-the-counter? Do you take any weight loss medications, for example,
No.
injections before the surgery?
no,
Okay. And I'm sorry, I want to ask you a sensitive question. Did you have any drugs?
no, doctor.
No. Okay. And I want to ask you, do you have any, how's your cycle? I'm sorry for that. Is it heavier or lighter than normal?
No, it's okay.
It's okay. And are you in a relationship? Have you?
No, doctor.
Okay. And okay. And have you got any history of? I'm sorry for that. Any needles or
No,
blood transfusion? Or, and I'm sorry,
no,
any
doctor.
casual relationships? I'm sorry.
No, doctor.
Okay. I see. And I want to any drug allergy you have?
No,
Okay. And have you do you drive?
yes,
Okay. Well, with this fit episode, I'm sorry to inform you, it's for your safety and the others on the road. We need to hold you from driving until we get to the root cause of that. Is that all right?
yes, doctor. It's okay.
Okay. And what do you do for living? Do you work?
No, doctor. I'm student.
Oh, I see. How much this affecting you? What happened?
It's happened suddenly, doctor. It's only one time today.
Oh, yeah, I see. We will help you as much as we can. Do you smoke? Cigarettes.
No.
Have you smoked? Okay.
No.
And do you drink alcohol?
No.
Okay, I see. And so, do you mind if I examine you?
Yes, doctor, it's okay.
Okay, I will start by looking in the vial. Is it the same as?
Yeah, same as outside.
And okay, I will start by looking any dysmorphic face, any.
No.
Okay, I will look in the.
2 minutes
I will look in
remaining.
the. 2 minutes. No, still not 2 minutes.
No, it's 2 minutes left. Continue,
Okay.
and we will add 1 minute for the consent. Continue.
So, okay, I will just check the hand grips. If there's any weakness in the arms or legs, ask the patient to
No.
lift the legs. And I will also, any bowel weakness?
No.
Hello? Okay, and I
No.
will check the reflexes. And pronator drift.
Normal.
And I will check the, okay, plantar response.
Normal.
That's a quick neurology that I can do, and I will listen to the heart, S1 and S2,
Normal.
and basal crackles, or
No.
in the back, just quick listening. And that's it. I will. Okay. What is your concerns, Mrs. Sarah?
Yes, doctor. Is that a epilepsy?
It's just early now to say. We don't know for now for sure. We will keep you under a close follow-up, but it's one of the possibilities. Any other concern?
Yes, doctor. It can occur again.
There is likelihood that this happen again. That's why we will admit you now for some workup, but we will let the neurology involved, especially for this point, some workup needed, tests to know better answer about this question. Any other concern?
No, doctor.
Okay, thank you.
Yeah, perfect answer to the concern. The best thing in this scenario. Okay, let's go to the examiner question. Dr. Amar and Dr. Abdullah, you can start.
So, can you present the case and differentiate?
Yes, so this is Mrs. Sarah, 20 years, and presented with an episode of first seizure, 3 minutes, generalized tonic-clonic with loss of consciousness. And she was having lost sphincter control, and she was post-ictal, prolonged post-ictal duration, typical of generalized tonic-clonic episode. That was not triggered beforehand by any illness, but she has a background of significant weight loss in secondary to post bariatric surgery. Apart from that, I could not appreciate, and she has also body aches, and she has a childhood absence seizure that has resolved. My differential diagnosis in this case is this episode of seizure, given her background of epilepsy. Well, my first differential is we need to rule out secondary issues such as electrolyte disturbance,
Like what?
like hypokalemia, hypocalcemia, severe sodium, also hyponatremia, and hypophosphatemia, or hypomagnesemia. And because of the body aches, which can be attributed to this electrolytemia. Other differential is this could be first seizure as part of in her background of in childhood epilepsy. So can be related to epilepsy syndrome, but that's in the second differential. Other differential diagnosis is that other differential diagnosis is less likely is cardiac arrhythmia related secondary to again electrolyte disturbance, but that's a far possibility.
Okay, so what you will do for this lady?
What I will do for this lady is she needs admission, and I will start by a bedside test of I will put Holter, and also
Holter?
Holter for ruling out an arrhythmia, and also I will do ECG to look for prolonged QT syndrome.
Okay.
And so she will need basic blood tests. She will need, again, sugar monitoring, although hypoglycemia is one of the triggering that need to be ruled out. I will do a basic blood count, looking for any abnormalities in the blood counts, inflammatory markers such as white blood cells, CRP, C-reactive protein, I mean. So any evidence of infection. I will look for the kidney and liver function tests, because any impairment can lead to also seizure. I will do ESR of a list value test. It's a list value test, actually. Okay. I will do brain imaging, CT brain, and she may require a later MRI scan to look for any evidence of structural abnormality sensitively. Electroencephalogram, so EEG, that may be done later on in the clinic as outpatient or under neurology input.
How you will manage?
She will need to be admitted as a first seizure episode to be observed, so that it will not be recurred. Multidisciplinary team approach involving neurology, involving physiotherapy, occupational therapy, if there is any impairment in, if there is any social issues need to be addressed, and in her mobility. And also we would look for safety at her home or social life, and also in her life at medical, in her study life. Yeah. So we will need to specific treatment is that at the moment she will not need anti-seizure medication unless that depends on the neurology input. If there are high risk features, she may need. If there's any abnormality in if there's any high risk that this will happen again, or any abnormal imaging that will need to be addressed and treated, and anti-epilepsy medication can be initiated under their input and advice. Ruling out other such as thyroid dysfunction or other electrolytes to be corrected.
Okay, thank you.
Yeah. I'm sorry, if there's any arrhythmia need to be addressed. Okay, thank you.
Thank you for that.
Okay, thank you, Dr. Amar. Dr. Ala, you can comment now, Dr. Ala, based on the skills.
Thank you, Dr. Abdullah. Well done. You did a good work in this scenario. You analyzed good seizures, and to try to confirm that it is actual seizures with good analysis. The good thing also that you asked about the blood sugar. But the thing that you should also have asked about trauma, if she had any trauma before the seizure. Any acute neurological insult, you should ask about trauma before it.
Yeah.
Okay. You did a good job regarding the analysis. You asked also about the past history, analyzed the weight loss was very nicely, okay, about it is intended or not, how you did it, and bariatric surgery. But also regarding the bariatric surgery, you should have asked about supplements. Did she receive any
Yeah.
supplements after doing the surgery? Okay, because this
Yeah.
patient was advised to take supplement and she wasn't taking any supplements.
Mm.
Okay. That's okay. This is regarding the history. Okay, the communication. You asked about the driving. You asked about smoking. You asked about alcohol.
Yes, I did.
Yeah, you asked about alcohol.
And
Okay, illicit.
drugs.
Yeah, illicit drug. Good question. Also, you asked about the female history, the family history. Okay, so only for the trauma and also analysis for she has body aches. Okay, generalized body aches. Maybe you couldn't link it with a problem, but you did it in the differential later and that she has electrolyte disturbance. About the supplements, she has also muscle cramps, she has circumoral numbness.
Mm.
Okay, so she has hypocalcemia
Hypocalcemia.
after the bariatric surgery.
Mm.
Okay, this is only regarding the history. The clinical examination, you did also nice clinical examination. It's like a fast neuro examination, and but you should have, if you elicited from the history that she has hypocalcemia symptoms,
Mm.
and also from outside before, like you are going inside, you have patient with a seizure. You should like prepared all the secondary causes with you that she may cause that it may cause the seizure. You should put all the electrolytes with you and
Yes, yes.
CNS infection, trauma, tumor,
Mm.
like this. You should prepare it with you and you try to ask about what is the most possible of them. So if it's elicited in the history that she has hypocalcemia and she had muscle cramps, she had body aches, she had circumoral numbness. So you should have examined hypocalcemia features also during the examination.
Mm.
Okay, you should ask for the torso sign. Okay, and also doing the chuvistic sign during the examination. Yeah, during the examination, added to the neurological examination that you have already done. Okay, the differential is good. You put the right differential for the case, and you put it even in the right arrangement with this electrolytemia, then the epilepsy. Okay, the hypocalcemia first, then the epilepsy. But yeah, if you allow me, like I have one small advice for you.
Yeah.
Don't try to go with the talking. Don't try to go with the talking, because when you are talking more, I think you are making more mistakes. Because I think you are thinking more. This the electrolyte disturbance causing seizure, okay, epilepsy causing seizure. You try to figure out any other thing, so you talked about cardiac cause, cardiac cause, then
I see.
yeah, and also the thing that during the discussion with the examiner, they have only 5 minutes. Okay, so you should allow them to ask you all the questions that they are preparing. Okay, because if they didn't ask you one question, they will mention in the feedback that you didn't answer the management, although they didn't ask, but because you didn't give them the chance to ask.
Thank you.
So,
Good advice. Thank you.
Don't argue with the examiner. Let him ask and you answer. Don't try
course.
to correct or to show him that I want to mean that. Whatever you said, he will judge on. If he had a chance to let you explain, he will ask you again. What do you mean by this? What do you want to say? But don't try to explain like he couldn't understand what's in your
Oh,
mind.
yeah.
Okay, it can give him or can give him
Bad impression.
exactly bad impression that you want to explain to me and like I didn't understand. So be simple, to the point. Give him a chance, as Dr. Ala said, to ask you more about what he want to ask. He should fulfill all skills, investigation, the clinical judgment, including the investigation and management plan, the differential, and the finding in the examination. So he should fulfill all the questions related to those skills. Give him the chance, and hopefully they will be kind examiner to listen to you. But again, there is limited time to present. 1 minute, for example, for presentation, 1 minute for the clinical judgment, sorry, 1 minute for the admission and the investigation, 1 minute for the differential, 1 minute for the management plan, and other red flag or safety netting at the 5th minute. Okay, you have 5 minutes for the discussion. Otherwise, yes, I think the case was hidden in the history by the surgery. That's why it's very important to ask about previous history, either medical or surgical or allergy or whatever. Dr. Ala, you finish your comment or still? Because I interrupted you.
It's almost
So,
finished.
okay.
That's it. Yeah.
Let's repeat the skills. Physical examination. You want
Physical
to give
examination will be a borderline only for the examination of the
hypocalcemia.
hypocalcemia symptoms. Yeah,
Mm.
hypocalcemia signs. And also the communication will be affected by the trauma. They will not forgive about trauma in any acute neurological insult.
Okay.
Yeah. But the good
Okay.
thing, he asked if he hurt or he injured himself. This is
During the
important.
event. That's why I repeated it again. What do you mean, doctor? That during during the that's why I repeated it. What do you mean by hit myself?
Okay.
You told during.
The next finding, he could pick up all the finding.
The findings only the hypocalcemia. He didn't check
So it's
for
still
it.
been
So,
line. Okay. Clinical communication, the history.
communication, the history of trauma. He didn't ask about the trauma.
So still borderline.
Yeah, and the other hypocalcemia symptoms also he didn't ask about.
Okay. The clinical judgment.
The clinical judgment was okay, but the thing that Dr. Abdullah was like mentioned, sometimes he was going away with investigations not needed, but okay, but he mentioned at least the investigation that needed for the patient, the EEG, the electrolytes, the imaging.
But yeah, I want to minus him in the point of arguing with the examiner, because believe me, they will not forgive it. Maybe they will fail you for the good things you did, all the scenario. Okay, even if you did go good, they might minus you because you are trying to argue them or to interrupt them during discussion. Okay, so they don't like this behavior at all. They want to listen to short answer to the point, and whenever he starts to talk, you have to be quiet, listen to his question. Okay, the differential, Dr. Ala.
Differential satisfactory.
Okay, good. So he mentioned all the electrolyte disturbance, epilepsy, and by the way, it's a seizure. It's a real seizure. It's not syncope. So it's a seizure, but for underlying cause, electrolyte disturbance or trauma, as Dr. Ala mentioned. And the third differential,
The epilepsy.
epilepsy itself. Yeah, having history of absence seizure.
Absence
So
seizure.
yeah, it could be complicated one. Okay. The concerns, since he was to the point, he finished all concerns, so I will give him satisfactory. It was good, really. The welfare
Yeah, welfare satisfactory.
maintained. Okay, means that he had 4 minus in borderline and 4 skills, so it would be 16 out of 28. Okay. Any question, Dr. Abdullah?
I may listen to the recorder, but just I'm sorry. Can you repeat the exact like the irritating interruption that I'm sorry. Maybe that's the trouble. I may not feel it, so that's the more troubling. So
It's okay.
Sometimes I'm
By the way,
talking like
it's
any other test, and you are continuing the same, and
okay.
the specific treatment. The thing
But
that
if I'm
I mean, don't go too much. You try to be specific for the specific investigations needed for the patient. If he is asking for extra, you try to figure out if there is any extra test you want to do.
okay,
Okay,
but
especially you mentioned by yourself ESR. Why ESR? I don't need ESR. You understand me?
yeah.
And the limiting of the time, because I had one case also in my exam before TIA, and I was like you, MDT, neurology, like this, occupational therapy, physiotherapy. I will bring the patient control of risk factors like this. Then the bell rang. I didn't mention the
Oh
treatment
my
for the
God.
yeah, I didn't mention the treatment for the TIA, the aspirin, and the other medication.
Mm.
I didn't mention that, and he mentioned in the feedback fail to manage in the ER like this.
Okay, you can
In the
listen again,
feedback.
Dr. Abdullah.
Yeah.
I think also, and Dr. Ala agree about the discussion way wasn't that much. Maybe the internet and the Zoom meeting different from the online one, from the sorry in-person exam
Oh,
or face
thank
to
you. Yeah.
face. But this is what I felt like you are trying to justify or to explain while talking to him. Maybe they will not have or give you the chance to do so. Anyway, just try to be short in your answer and let them finish the whole exam uh, criteria of
Yeah.
questions. Yeah.
Can
And
we? I have a
again,
comment.
the
Oh yes, go
history.
on.
Yeah, sure. I won't
No,
say
just say
that
your
the
comment
history was
first.
not wasn't. Yeah. My comment regarding the history, the systemic review question wasn't in systematic way. I didn't find the question to the system itself, right?
So it
Dr.
wasn't.
Ala also can.
So first I started with the neurology, and then I went to I drift to finish the other aspects, past history, medication, and then I went back to the systemic review in the end. But the systemic review, when I went to the abdominal or gastro, um, I think that was the case. We were distracted by the surgery. Like we went again to that. I think I'm not sure what I don't remember, but we were talking about the past in the systemic review,
What I
which
mean,
made
the chest, the cardiac. Did you ask
no.
about
I did
them?
ask. I did ask. Yeah. I
Okay.
did ask about chest pain, palpitations, and if previous fainting or
Yeah,
near fainting.
previous genitourinary questions, musculoskeletal, all of them was covered, right? Okay.
Yeah,
For
I
other,
did ask
for
about.
okay, the last comment before your question, the best approach for seizure and syncope, the question will be through three steps: before, during, and after. Any seizure or any fits or any syncope, ask in this way: what you were doing before, what happened during, and after you wake up, what happened exactly. And during these steps, you have to know, is it real seizure or epilepsy or just fainting or shakiness or hypoglycemia or cardiac syncope, okay, or vasovagal. It will not go away from these questions or these titles, okay. Being have a history of epilepsy, so the most top differential will be epilepsy related. So recurrence of epilepsy, non-compliance with medication, interaction with the medication, and still no response. So they might increase the dose. It will be appear through your questions. By before you will be as aura as Dr. Omar already, Dr. Abdullah sorry mentioned it. Did you see something? Did you hear something? So it will go with epilepsy. Or during the attack, if he bite the tongue, if he lost the control over the waterwork or back passage, or his eyes rolled up, this finding will be going with seizure. After, what will happen after? Patient will be confused. Okay, as in this scenario, I felt myself still not in my awareness, couple of minutes, maybe hours, still patient confused, which is called post-ictal state. Okay, so this is for epilepsy itself. Patient will have prior aura, then during the attack, he will bite the tongue, roll his eye up, and the loss of control over the water work. After, he will have post confusion or post-ictal confusion. What about the other manifestation? The syncope, for example, patient either he will faint, the cardiac syncope, the patient will feel palpitation before it. Okay, is it associated with seizure? Not usually. So the syncope of or the cardiac syncope not usually having a seizure unless there is cardiac arrest happen. The patient might have decreased blood flow to the brain and he might have seizure. But classically and usually it's not associated with seizure. This is regarding the cardiac syncope. The other will be hypoglycemia. And by the way, all of them are differential to each other. The hypoglycemia patient will feel hunger pain before. During, he will have a sweating and shakiness of the hand. After, he will be fine whenever he take sugary diet. And he will tell you, doctor, yes, they found my blood sugar low and I took sugar and I have been fine. This is regarding the hypoglycemia. Electrolyte disturbance, maybe according to every electrolyte. For our case today, hypocalcemia, the patient will have perioral hyperesthesia, or he will have the manifestation of hypocalcemia, tetany, or whatever. And it will be related to past surgery or past medical or past history of vitamin deficiency, malabsorption, diarrhea, patient on supplements, and he's not taking the supplements, whatever. The fifth one, if we suspect, so let's repeat them: the cardiac palpitation, the global cardiac palpitation, the epilepsy, as we mentioned, and the hypoglycemia, as we mentioned. Yeah, the stroke, the central TIA or stroke. Patient might have seizure, but you might have weakness, either unilateral, monoplegia, or whatever, or loss of vision. Okay, dysarthria, facial deviation, all of them will be as a TIA or central cause. Maybe associated with seizure, yes. Any stroke might be associated with seizure. These are the 5 causes and the most important causes of seizure or syncope or fainting in exam. You have to roll them out in order. Okay, cardiac, again, cardiac, hypoglycemia, epilepsy, TIA, stroke, electrolyte. I hope it's clear for now. The comment for the Abdullah, what you want to ask?
I have actually 2 comments. One after your comment. I would disagree. Like medicine also, as Dr. Omar said, it's not 1 plus 1. So I would disagree in something in your comment that the cardiac does not cause seizure. Well, why
Cardiac
not?
does cause syncope.
Well, arrhythmias can cause. There
Yeah,
is a common.
I didn't say it's not happen. I said it's not usually happen, but it happens. I said that.
Okay.
Yeah,
No,
I
I
said
thought you
it's
said
not.
only arrests can cause. So
No.
no.
This is the explanation when it happened, but it's not mandatory to not to have a seizure. Yeah, no, it
Okay.
might be there. Okay, yes.
Okay.
That's the
The other
second.
thing is, since we are talking about bariatric surgery, it's a very common topic, and well, I don't know if anybody prepared something like hypocalcemia. Is it the commonest electrolyte related? I don't know. Like that's an interesting topic, and we should know. It's very coming increasingly common surgery now.
Yeah,
And we should be.
hypocalcemia, hypoglycemia, post-dumping syndrome. Okay, and some vitamin deficiency, but the vitamins will go more with anemia, with feeling fatigue, with peripheral neuropathy, vitamin B12 deficiency in this way. But for the seizure, hypocalcemia, okay, it could be the reason. And the other thing can cause seizure, but it's not related to the post bariatric. I mean, other electrolyte can cause it, hyper and hyponatremia. hypo and hypernatremia, which is not the case related to the bariatric surgery. The sodium absorption is not in the GI, it could be in the liver, in the kidney, sorry. But the calcium, as most common cause of post-bariatric calcium deficiency or absorption, will be in the post-bariatric one. The other electrolytes, I don't think will be
So,
included here.
Dr. Bassem,
Magnesium, yes.
For the if the bariatric surgery involved the duodenum, then calcium would be affected because calcium absorption is in the
Yeah,
duodenum. So it depends on the type. If it's affecting the I think it's the wine Rowan Y or wine row.
yeah.
I'm not that surgically well
Wine
trained,
row,
but
yes.
one row. If it's for weight reduction, because there is some there's gastric sleeve, there's a sleeve gastrectomy, and there's so many types. So it's removing part of the stomach or diversion. If they are doing diversion, if they are playing with a small bowel, then they are bypassing the duodenum, which is the most of the electrolyte is being absorbed from the duodenum, mainly calcium, iron. And from the terminal ileum, I think it's the bile salts and the vitamin B12. So calcium remains very high, and from the shortening of the bowel, the potassium and because of the diarrhea, the potassium will be affected. And if the patient does have other comorbidities, then the sodium starts to be affected because of either medication use, maybe a PPI, excessive BPI use, or etc. Then the sodium will be affected, but calcium remains on the top. You can correct me
Yeah,
if
exactly. Yes, yes. It's raw in wine, not wine or raw in wine.
wrong.
Yeah, raw in wine surgery. And this is the most common and most dangerous surgery, having a lot of complication. Why? Because they are removing most of the duodenum and part of the jejunum. Other like bariatric of sleeve or cutting part of the stomach, it's not that much having a lot of complication because it's a part of the stomach will be either clamped or removed. But the most dangerous one with a lot of complication, the raw NY, because they are removing, as we said, the duodenum and part of the jejunum. Patient should be kept on vitamins lifelong, supplements supplements and vitamins. Any stop of these medication or supplements, the patient might have deficiency, either vitamin deficiency or hypocalcemia or other electrolytes imbalance. That's why he should or she should be kept lifelong on these supplements. Even anemia can be there, by the way. Okay, for the iron also absorption, for the other vitamins absorption. So the take-home message: whenever you have bariatric surgery, the major one, you can have a lot of complication in cases. Hypocalcemia, it came as post-bariatric epilepsy or seizure. You might have also vitamin B12 deficiency, and it will be present with peripheral neuropathy. Or anemia itself can be also associated with vitamin B12 deficiency. So when any of these might happen, be careful about the history. It might be in the past medical or past surgical. Okay.
And do you remember, Dr. Basim, when I was practicing, I was prompting to asking about weight losing medications, the Ozempic and etc.
Yeah.
So in my exam, when I asked about it, the patient was already taking the
Mm.
that. I don't know how this can be linked to the polymyalgia rheumatica and etc. I'm still trying to figure out, but she was saying, that, "Oh, I'm already on self-purchasing the um,
Sometimes
the
it's not.
GLP-1 inhibitor." Um,
Yeah. Sometimes
she
it's distracting, not as linked related or.
But this is but this is she's type 2 diabetic, so um um I was it's not used commonly in type 2 diabetic.
No, no,
Um
but nowadays they are using it for the reduction of the weight.
Yes, so this is one of the things
Yeah.
we should keep in mind to ask the trendy things. It's one of the
Yes,
trendy
yes,
things.
right.
So
Yeah. Any medication a patient is receiving might be related to your complaint. So take care about any medication and show me your medication list. Put it in your approach usually. Okay. Yeah, let's go to the marking. How? Because it's a good question, and I think most of the candidate doesn't know how the skills going. And by the way, you might fail because of this thing. You couldn't understand how the skills are going on, and sometimes you might fail in one skill for 1 mark. And this happened with me. I failed my attempt, the first one, because of 1 mark in the clinical communication skill. But overall, I passed the all pass mark. What the problem? It was history taking and the clinical communication. So be careful. You can or you might mm, fail the exam because of one skill and 1 mark and one skill. If you fail the all pass mark, of course you will not pass. And all the candidate fail the pass mark, they will have a lot of skills failed. In the opposite, no. You might have the pass mark, but you might fail in one skill. Okay, you got it. I mean, if you fail the pass mark, definitely you have many skill not passing because there is cut off to pass the all skill. Anyway, let's go to examiner judgment. How they judge on your performance. There is two examiner. Every station there is one leader, and the other will be just listener or just observing your performance. He might be more focusing on you rather than the leader one. Why? Because the leader is giving you the question. How they judge after the performance, the history, the time for examiner, the leader will start to ask you, as I said, the skills of clinical judgment, differential, investigation, presentation, and management. How they can judge? If both examiner give you satisfactory, means that you got 4 out of 4 in this skill. Okay, in every skill and this skill. For example, clinical communication. No, yeah, let's say the clinical communication based on the history. So if you satisfy the examiner, both examiner, they will give you 4 out of 4. What if one give you borderline and the other give you satisfactory? You will get 3 out of 4. What if both of them give you borderline? They will give you 2 out of 4. What if one of them give you unsatisfactory and the other one give you borderline? You will get 1 out of 4. The last thing, if you unsatisfy both of them, they will give you unsatisfactory, means that 0 out of 4. And this is the worst mark. 0 out of 4 in one skill. It's very dangerous, not only in this station, in other station, because every station have multiple skills. If you don't fulfill the skill in the all exam, you might fail the all exam. So means taking 0 out of 4 in one skill, it's very risky not to pass the skill in the all exam. That's why I prefer to get, of course, to get satisfactory in all skills. But the worst thing to get borderline in both. So 2 out of 4. And satisfactory in one skill is very risky. Even one station, it will be risky if you have unsatisfactory in another station. Be sure that if you have two unsatisfactory in one skill in two station, you might fail the exam. It's not necessarily, but it might be that like this. So at least borderline in every skill to have passed the skills or the pass mark of the skill. Okay, for example, let's talk about concern. Concern, because this happened with me. I missed a concern in one long clinical consultation. I missed it totally. I didn't do it at all because the time was managed inappropriately. So I didn't do the concern when they asked me 2 minutes left. I didn't ask about the concern and the time already passed. I didn't do the concern in this station. It was long clinical consultation. Okay. So I know that I will get 0 out of 4 in this skill in particular. What I should do in other station, I should fulfill the all concerns in other station. Why? Because if you talk as unsatisfactory in this skill in another station, you will fail the exam definitely. So you have to have satisfactory in the skill of concern in the other station, all of them. You have a chance to lose 1 mark only in another station beside the one I missed. Okay, so it's the pass mark for the concern was, I think, 12 out of 16, because concern in 4 station, the 2 communication and the 2 long. 12 out of 16 you will pass. 11, I think, you might fail the this skill, and further you will fail the all exam. So what I have to do to fulfill and not to forget the concern in other station. Again, if you forget 2 concerns in 2 stations, definitely you will fail the exam. Okay, this is the best example and the least example to know. Of course, the other skills are the same. Any station, if you don't do the full examination steps, they will consider that you unsatisfactory in this skill. Other skill in another station, same skill in another station, if you don't do satisfactory, it will affect the whole skill mark, and it will be a risky not to pass this skill. Okay, whenever you do bad in one station, this is the take-home message. Whenever you do bad in one station, try to compensate in other stations. If you do bad in 2 stations, sometimes you might not pass this exam. Okay, so the take-home message: two station with bad performance, be sure, or you might not pass this exam. That's why usually we are saying don't think about previous station. Think from zero and proceed further. Okay. I will try to make a video about how the skills are going and the judgment, and I will publish it soon. And let's go to the last comment. Doctor, successful of communication. Yes, 12 out of 16. Successful of consultation. No, don't ask about success of consultation out of 28. It doesn't matter. You might have 10 out of 28, but you fulfill most of the skill by borderline. So let's say that the borderline in every skill in the long clinical consultation, it's 7 skills. 7 times 12, 14. If you gain 14 out of 28 in this long clinical consultation, and if you have good marks in other station, you can pass the exam. So I cannot tell you you have to get 20 or 28 out of 28. No, you might have to 14 out of 28 in one long clinical consultation. But if you got good mark or full mark in other communication or other long clinical consultation, you might pass the exam because you fulfill the skills marking, not only the all station. So don't look at the all station mark. Look at the skills mark. You have to have at least borderline. Again, unsatisfactory in one skill in any station put you a risk to fail the all exam because of this skill. Okay, I'm not talking about more than one skill. I'm talking about one skill only. If you have unsatisfactory in one skill, you might have risk not to pass. Of course, add to this, if you have unsatisfactory in 2 skills, the risk will be double. Okay, unsatisfactory in this exam in one skill, you might not pass the exam. However, you might pass the exam. But unsatisfactory in 2 skills in this exam, you might have double the risk not to pass the exam. What we have to do, we have to get at least borderline in any skill, at least. And the best, of course, the optimum to get a full mark, which is satisfactory in every skill. Yeah, I hope it's clear for all. Sorry, the station today was the session today was long. It was 1 hour, I think. So sorry, 2 hours. Lengthy one, but good cases by Dr. Abdullah and Dr. Omar. Sorry, Dr. Abdullah and Dr. Ala. Also, Dr. Amr commented good about the first and second scenario. Valuable comment as usual. Anyone has question before ending the session?
Yes, thank
Yes.
you, Dr. Basim, for coordinating the session. The issue of the clinical signs, actually, how to, like, I know practice improves that, but that's the only issue here in Zoom. We cannot, there is the only barrier in the clinical signs is the discrepancy between the online
Yeah.
and the practice, and it's very difficult. Like, it's
Yes.
the most difficult skill. I also failed because of this.
Okay.
There was a patient with they brought a patient. I'm awaiting the feedback from the so they put it as a mixed upper and lower motor neuron, and I think they were hinting toward the spasticity in the lower limb. I didn't see the spasticity from the beginning. Maybe it was something like because spasticity by nature it only comes when you with the speed
How do
of
you
the
look? How do you look for the specific, Dr. Abdullah?
yeah. Um, so it's as a tone examination. You
Yeah.
so you will so I was assessing the lower limb. I was flexing the knee
Yeah,
and
inflexing the knee. So it's inflexing the knee. If the ankle has raised from the bed, this means spasticity. Forget about the tone because sometimes the patient might be stiffing his leg. Forget about shaking the leg. It's not judgmental of the tone. This is the lesson that I've learned. If you are bending the knee very quick, if then the heel left the bed,
yeah,
you should suspect when you are shaking the
suspect,
patient
yeah,
leg what you are looking for. You don't look for the leg, you are looking for the ankle. Is it leaving the bed or is it still on the
yeah,
bed? This is
yeah,
this lesson I've learned it very hardly.
yeah,
Okay.
yeah. Thank you so much, Dr.
Yes. And as well as the movement of the whole limb from the shoulder.
Yeah,
When you roll them, it will be moving as difficult. But for the normotonia, supposed to be easy. And the flaccid one will be moving like nothing. It's flaccid.
But
Okay.
sometimes, Dr. Bassem, from repeating examination, or if the patient, for example, does have fixed joint because of Charcot or anything,
Yeah, yeah,
in my
yeah.
case, his when you roll his leg, it will seem stiff.
Mm-hmm.
So the advice that I've received from one of the neurologists,
Yeah. To
don't
raise
look
it up.
for the
Yes.
rolling. Don't
Mm-hmm.
look for the, if you suspect it from the rolling, confirm it. Look to the
By
heel.
raising.
Look
Yeah.
to the heel when you are shaking like bending the knees.
Yeah.
Don't look for the knees. Look for the heel.
Yes, of
Train your
course. The
head to
heel.
look. Yeah,
Yeah.
I'm just
Yeah.
that's nice.
because in my first attempt, I thought that the patient does have hypertonia, whilst in the fact, no, the patient was making his leg stiff, and
Mm-hmm.
the patient was not listening to what you are saying, and
Yes.
this happens.
So the best way is to carry the knee and you will see if it's flexed or no. Yeah. Thank
Yeah.
you, Dr. Amar. One more comment.
Uh,
Yes.
Sorry, Dr. Oman, I didn't quite get your explanation. Can you just go by it slowly because you
Yeah,
said when you raise the
we
knee.
cannot hear you, Dr. Henry. You're muffled. Your voice is muffled.
Uh, Dr. Henry, if you meant how we are assessing the hypertonia, so the first thing you roll the leg on the bed when it's extended. So
Okay,
sometimes you might get a sensation. Oh, is it really stiff? So you bend the knees very quickly, okay, to look for the spasticity. So when you are looking, you don't keep your eyes on the patient knee. You look down to the patient heel if it's leaving the bed when you are bending his knee or not. If the patient heel remained on the bed, this is not hypertonia. If the patient heel left the bed as you are bending the knee, this is a true hypertonia.
All right, thank you very much. Thank you.
Yeah, thank you, Dr. Henry. Doctor, but to give you a chance to communicate well, stressful condition, same situation of exams, that's practice permit for you in many cases. Yes. What is the benefit of this meeting is to gain confidence, because some skills in the meeting you can gain, but others like examination you have to do it by yourself. So I cannot guarantee you to have the examination finding from the Zoom meeting. No, but at least you are repeating the steps, you are gaining the confidence how to repeat the steps quickly without thinking. By the way, you have to do the steps by heart. No time to think, what should I do now? No, you are doing it by heart, step after step, without thinking. This is what I can help you in this session regarding the skills of examination and finding. Clinical communication, you can gain it from the meeting. The clinical judgment as well, you can gain it from the meeting. The concerns, the welfare, you can gain them how to maintain them in the exam also from the meeting, the differential as well. So all of the skills you can gain it from any Zoom meeting or online meeting, but the examination finding you should do it by yourself. You have to teach yourself how to pick up the finding from every patient I see or I have seen in my life or in the clinic or in the department. Try to find out any patient, to examine him or to examine her, to find what he has, and I should pick up them. Okay, use your stethoscope, your hammer or your hand skills. Try to pick up these findings from any patient you have seen in your life. Okay, otherwise the online meeting will not help you to pick up the finding. No, it will help you to do the physical. So the only missed skill will be the identify the finding. But the clinical examination steps or physical examination steps, you can do it even by saying, I will do 1, 2, 3, I will do 1, 2, 3, because you are doing them. But when you pick up the finding, if you have pick up the finding in your real practice, not in your online, of course, because you cannot pick up the finding from the online. Okay. Thank you, Dr. Again, Dr. Ala and Dr. Abdullah, and as well as Dr. Omar. Thank you, everyone, for the attendance today.
Thank you,
Uh,
Dr. Bassem.
Yeah,
You,
most
Dr.
welcome.
Qasim.
Most welcome. Okay. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam.